if you can't see me. Good evening, everyone. Perfect. So I really want to thank you all for joining us here at Standard Distributors Showroom, a beautiful setting for what is the first in our series of health talks. I'm your host, Shane Seeley, Communications Specialist with the Queen Elizabeth Hospital, and I'm really delighted to be here with you tonight. We are honored to have with us some of the leading experts in the field of ophthalmology who will share their valuable insight and the latest advancements in eye care, and that's all happening at our hospital, the QEH. Throughout this session, we will cover a wide range of topics, and whether you're here as a healthcare professional, a student, or simply someone interested in learning more about eye health, we are sure you'll find this talk educational and definitely inspiring. You'll also have the opportunity to ask some questions as well, those of you here in the audience, and then we have our audience online with us as well, joining us from wherever you are. We just thank you for sharing this time with us. As I said, this is all a part of our 60th anniversary celebrations and our outreach. Our 60th anniversary committee has been working hard to ensure that we get into the community in whatever form or fashion and really meet the needs and demands of what is a demanding public. But before we begin, I would really like to extend a warm welcome to our distinguished guests. Let's start with the head of the ophthalmology department, Dr. Trevor Drakes. His specialty is in general ophthalmology. Dr. Drakes holds a double bachelor's degree in medicine and surgery from the Mona campus of the UWI, which was awarded in 1990. He returned to Barbados, and after completing his internship, he joined the ophthalmology department at the Queen Elizabeth Hospital in 1992. In 2013, Dr. Drakes became a fellow of the Royal College of Physicians and Surgeons, Glasgow, specializing in ophthalmology, having gained a wealth of experience and honing his surgical skills. He currently serves as the head of department for ophthalmology service at the QEH, where he offers specialist eye care and teaches general ophthalmology at both the undergraduate and postgraduate levels. We thank you for being here with us tonight. And I think we can. Also joining him on the sofa is Dr. Charles Pierce, a medical retina specialist. He's a UWI graduate of the class of 2001. Ophthalmology specialty training he earned at the QEH and then in the UK as well in a training program there. He completed a fellowship focusing on medical retina, ocular genetics, ocular oncology, and uveitis at Mooresfield Eye Hospital. He completed as well a research degree from the University of Southampton in transitional research focusing on macular degeneration. He also worked as a consultant ophthalmologist in the UK with a subspecialty interest in medical retina. Currently, he's working as a consultant with us at the QEH, and he's also an associate lecturer in ophthalmology. He's the clinical lead for the Barbados Diabetic Eye Screening Program in association with the Barbados Diabetes Foundation. A medical director as well for Abalon Trust in the UK, and that's a charity dedicated to eye health in Africa and the diaspora. His work speaks for itself. Right next to him is Dr. Kaiwa Clark, a glaucoma specialist. Dr. Clark is an ophthalmologist with special interest in glaucoma, who graduated from the University of the West Indies as well, with a Doctor of Medicine in ophthalmology. He is also a fellow of the Royal College of Ophthalmologists in London and the International Council of Ophthalmologists. He hopes to use his expertise to help prevent avoidable blindness through public education and awareness. We are thrilled to have him here today as we look forward to that stimulating exchange of knowledge and ideas. We also have Mr. David Callender, a general and pediatric specialist. Mr. Callender has the role of adult and pediatric ophthalmologist in the eye department, providing services to adults and children for several decades. He also oversees the school eye clinic based at the Winston Scott Polyclinic and assists with UWI's postgraduate training program. His accolades are long, but he condensed them for us tonight, and we thank him for his service. So without further ado, we'll get started very soon, but before we get started, we must say a big thank you to some of our sponsors tonight, definitely Standard Distributors, allowing us to use their beautiful showroom. I would like to welcome Miss Alexia Halliday to give a few remarks and welcome us here at Standard Distributors.
You to our showroom in Wildy this evening, and to those of us joining online, thank you for tuning in. Tonight we're excited to host the first in the series of the Queen Elizabeth Hospital's Public Health Talks, Eye in Focus. This evening's presentation will delve into various medical conditions affecting the eye, offering valuable insights from top experts in the field. Standard Distribution has been a proud fixture in the Barbados community for 65 years, just 5 years longer than the QEH.
Wow.
Partnering with the QEH to host this event is our way of giving back to our loyal customers who have supported us throughout the decades, and we hope to continue serving you for another 65 years and beyond. Please retain your ticket stub from this evening's event. As a token of appreciation, you may present it in-store before the end of June 2024 to receive $50 off of your next purchase of $100 or more. It's our way of saying thank you for your continued support. We now invite you to sit back and relax in the comfort of our showroom and enjoy this evening's presentation by our 4 esteemed consultants of the Queen Elizabeth Hospital's Ophthalmology Department. We are confident that you will find it educational, engaging, and eye-opening. Thank you once again for being here, and we look forward to an enlightening evening.
All puns intended there. So let's get started with our discussions tonight. First, to take the stage, well, he's here on the stage, on the couch with us, will be Dr. Trevor Drakes. Of course, he's the head of the ophthalmology department at the Queen Elizabeth Hospital.
So I'll just wait until my presentation comes up.
Right.
Good evening to those inside the studio. Good evening to those who are streaming online. I have the pleasure of going first, and today I'm going to speak about cataracts. But in addition to speaking about cataracts, I'm also going to mention some things that I've seen over the years of practicing at the QEH, which I think will be helpful if you ever have to come to the eye clinic. Next slide. So who are we? We could be considered a small department, and we consist of 2 areas, the eye clinic and the eye operating theater. The eye clinic is found in the Lions Eye Care Center. You can click again. And the arrow is pointing on the 2nd floor of that area because that's where we're located. Our eye theater, if you click again, is located right up in that little corner there on the 8th floor, on the 3rd floor of the main building in the main operating theater suites. So as a department, we provide what can be considered primary, secondary, and tertiary eye care. It basically means we do what we're doing now, which is education. And then if you have any problems with your eye, we may perform surgery or do anything else to keep your sight going or to restore your sight. Next slide. So this slide has quite a lot on it, but the important thing here is it takes a team of workers to give you the eye care to the public. We actually have a team of about 40 people And as you can see in the breakdown here, we have various grades of staff. But the important thing here is that it takes this team to serve the community that we are serving. So what did we do for 2023? And I want you to take these figures into consideration, bearing in mind that we are just coming out of a pandemic. So for last year, there were 21,000 patients booked. Click again. We did 828 surgeries in spite of the challenges that we had. And the important thing I want you to realize here is that 60% were cataract surgeries, because a lot of the times within the hospital and outside of the hospital, everyone thinks that it's all about cataracts. But as you can see, 40% of our work is something else besides cataracts. Next slide. So let's get on to what I'm actually going to speak about. What is a cataract? In my years, once you mention a cataract, most of our patients, they hold their heads down and they think immediately that it's surgery. But simply speaking, a cataract is any opacity of a lens. Next slide. So, as you can see, I have the lens label here, and you can think of the lens like being in a camera. What does it do? It helps to focus information onto the back of the eye so you can see a clear image. What happens in the cataract is that the lens becomes cloudy. Next slide. So I put this slide up because all of these are cataracts, different types of cataracts. So if someone says to you that you have a cataract, it could be anything. It doesn't necessarily mean that you require surgery. It doesn't necessarily mean that you need to panic. All of these are cataracts. Next slide. So who or what gives you a cataract? Nobody's absolutely sure what the exact cause is, but you can be sure that if you live long enough, you will get a cataract. And there are some people whose family has a history of cataracts. If you're a diabetic, you're more likely to get a cataract at a younger age. If you've had a serious eye injury, you will also get a cataract. Some people who have had surgery on their eye before will also get cataracts. Likewise, there are some medications that you take, such as steroids, which increase your risk of getting a cataract. And as you can see from here, while the evidence is not very strong, smoking, drinking, spending too much time in the sun also increases your risk of cataract. So therefore, if you look at this, the ones that we can modify, you can certainly stop smoking if you want to. You should. Try not to drink too much alcohol and reduce your exposure to the sun. Wear a hat, put on some shades. Next slide. So if you remember the slide we had before, we showed the lens was clear and the light was focused onto the back of the eye. But with the cataract, what happens now is that the light is all scattered and therefore it's not focused onto the back of the eye. So how do you know that you actually are not getting this light focused onto the back of your eye? Next slide. So this is what happens. Your vision becomes cloudy and it gets progressively worse over time. If you look at lights, you may see rings around them. You may even have double vision, so you could be looking through one eye and see more than one. Your vision at night becomes more difficult, and you may actually find that lights, bright lights, you're driving at night, you may find that the lights actually do in fact hurt your eyes. So I would say if you are experiencing these things, then you should make an appointment to actually see either your regular doctor, an eye care professional, to see if you do in fact have cataracts. Next slide. So I've kind of jumped ahead a bit because I'm going to assume that you have been to your doctor, you've been to your eye care professional, they've said to you that you have cataracts, I need to refer you to the QEH. And these are the problems these are the things or the challenges that I think I've seen over the years. Please take a note of your appointment time. Lots of patients don't know the appointment time or they come too early. Ensure that your contact information with the QEH is up to date. It is amazing how many times we have to make changes in appointments just for the simple sake of flow, where the contact information is not up to date and we cannot reach those patients, and therefore they either show up at the wrong time or we waste a lot of their time. If you're coming, arrange for your next of kin to accompany you, because if you're coming, especially for your first appointment, chances are you will have your pupils dilated and your vision will in fact be blurred or even more blurred than it was to start with. Bring your glasses with you if you have glasses, because we need to check your vision with the glasses. If you're on any medication, this is a big one. Whether they're over the counter or these are prescribed medications, you need to bring them with you. Or if you're not going to bring them with you, you certainly need to have a list of them, because we need to know what you're on. And as I put at the end, tongue in cheek, don't forget your eyes and bring a sweater, because the eye clinic is cold. It is very cold. Next slide. And this is all in bold, because the important thing I want you to know is if you are actually referred to the QEH and you have cataracts, everyone who has a cataract does not require surgery. It may simply that you need to monitor it. We may suggest that you go back and you have your glasses updated, but everyone does not require surgery. A person who requires surgery is someone who has a cataract, but they are now beginning to have problems with their quality of life. So you can think of it, an older person, you may get cataract at a later stage, but a young person who's working, who's having difficulty driving, who can't perform their job, then you may do their cataracts at an earlier stage. But the definitive treatment for a cataract will in fact be surgery when you do reach that stage. I'm not going to get into all the various surgical techniques. The important thing here is that what happens is that we use a method and we take out your cloudy lens and we replace that by an artificial lens. So if you look down in the corner here, down to your right, bottom right, that is what most of the implants that go into your eye look like. Breaking it down quite simply is essentially a piece of flat plastic which replaces your cloudy lens, but it now has power and it helps to focus the image into the back of your eye. Next slide. One of the other problems we have is that you've waited a long time to get your cataract appointment. You've waited a long time to get your cataract surgery. Then on the day of surgery you get canceled. And a lot of the times cancellation is because of patients have underlying medical issues which are not controlled. The two biggest ones are blood pressure and diabetes. So don't spoil your chance. Make sure that you take your medications. Make sure that your blood pressure remains controlled. Make sure that you have diabetes. If you know you're an anxious person, go to your doctor. Make sure you get something to calm you down just before. Try to get a good night's sleep before your surgery, because you really don't want to come and then hear that we've had to put off your surgery. It's one of those things that is very disappointing to patients. I'm actually going to end this talk by talking about cataracts and some cataract surgery myths. Cataracts are not growths on or inside the eye. It is simply a clouding of the lens. They are definitely not contagious. Elderly people are not the only people who can get cataracts. As Dr. Callan may allude to, children can get cataracts. Young people can also get cataracts. This is a big one. Before, you had to wait until your cataract became, quote unquote, right. But you do not have to wait for your cataract to be advanced or right before surgery can be performed. Cataract surgery is a very safe procedure. It is not painful. Another one that I hear quite often is that your patients come and they want to know how you're going to do your surgery. Are you going to do it by laser? My friend had it done by laser. I said, where did they have it done? Was it done in Barbados? Yes. I said, no, they did not. Cataract surgery in Barbados is not done with the laser, but that's not to say that you cannot use a laser in surgery. That is certainly done in other places, but we do not do cataract surgery with a laser. Recovery after the cataract surgery that we do is quite fast. Usually the eye is completely healed up by 6 weeks. Cataract surgery can in fact make some people glasses free, but most patients will require glasses to fine-tune their vision afterwards. And at the bottom here, for all those who go elsewhere and somebody tells them you can get some drops so you can take this and prevent yourself from getting cataracts, eye drops or medicines cannot. dissolved cataracts. So I hope this, just gets rid of some of the myths or breaks that. Maybe it may have raised a few questions, but at least I hope you have a clearer understanding of what it means when you have a cataract and what the process is that you will go through when you come to the hospital. So, next slide. Thank you very much for listening, and thank you very much for your time.
Thank you very much, Dr. Drakes. You definitely cleared the space and made us a whole lot more, or put us in a better understanding of what really a cataract is and how we should approach, or how we should make our way, when we make our way to the hospital, how we should navigate to have that condition dealt with. We will have questions and answers coming on to the end of the presentations, so you can hold your questions, keep them in your head, or you could make a little note and you can present your questions to our consultants here. Up next, to present on his topic is Mr. David Callender, pediatric ophthalmologist. He's also a general ophthalmologist as well. And you hear me say Mr. all the time, and I know that Mr. Callender will explain why I say Mr. instead of Dr. Callender.
Good evening. Good evening, attendees. Good evening, listeners. Mr. Seeley has sort of paved the way for me to make this explanation. We always ask, are you a Mr. or a Doctor? Well, we're all Misters. Those of us who receive a UK qualification in any surgical specialty except obstetrics and gynecology are usually called Mr. in the UK. Some of us prefer to be called Doctor. It doesn't really matter, but some people insist on calling us by the title that they think is correct. So I'm Dr. David Callender, Mr. David Callender, it doesn't matter. I want to talk about pediatric ophthalmology, not at the QH only, but in the public setting. I chose this topic because there's a very intimate relationship between what we do in the school like clinic and in the hospital. Most of the doctors who work at the polyclinic, in the school like clinic, also work in the hospital. And patients who are seen over there at Vincent Scott sometimes are sent over to the QH and vice versa. So there's a very intimate relationship. So they not choose only for the hospital. That's it, please. So I'll give a broad overview. We've been seeing children since the late 90s with problems coming to the QH and then also at the Vincent Scott Polyclinic. Our children are sent to us on a referral basis primarily from outside doctors, polyclinics, pediatricians, in-house referrals from various other departments or pediatric unit, and NACU. We also get emergencies coming through from the accident and emergency department and from doctors outside the hospital. So our referral basis is wide and varied. Next. Over the last few decades, we've recognized that most of the problems we see in children are refractive errors. This was also borne out in a study done by some of our junior doctors in 2019. Most of the problems are the need for glasses. And I mentioned the word amblyopia there because that's what we call lazy eye, which actually refers to the vision in a particular eye, where the vision is not as good as it could be. It doesn't refer to a droopy eyelid or misalignment of the eyes. That term means the eye is lazy, not seen as good as it should. If refractive errors go uncorrected for a long time, one or both eyes may become lazy in their vision. We also have lots of cross-eyes or squints. The term cross-eyed is used mainly for eyes that turn in, but we also have squints where the eyes turn out, but they're all called cross-eyes. And we see lots of allergic conjunctivitis every year. Initially, it used to be during the dry season primarily, but now with the Sahara dust, I'm seeing it all year round. You also get lots of trauma coming through A&E, primarily, and as Dr. Drake said, we see our share of congenital or developmental cataracts in children, or from trauma as well. And we have lumps and bumps around the eyelids, or on the eyes themselves, and we have other congenital abnormalities affecting the lids, like droopiness, or swelling on the eyeball. We also do lots of screening in children. Every child who's diagnosed with diabetes is sent to the eye clinic within a year of diagnosis so we can check them for diabetic retinopathy. We never see it, but we're obligated to look. We also screen all premature babies born below a certain birth weight, which is 1,500 grams or less, or 31 weeks gestation or less. All these babies are screened either on NICU, if they're there long enough, or on first week after discharge, if they're discharged before the time for screening comes up, which is 4 to 6 weeks after delivery. And all sickle cell patients seen in the hospital, either on the ward after a crisis or in clinics, are sent to the eye clinic for screening. These patients may have problems with their circulation in the back of the eye and may need intervention. And if you don't screen and treat at the right time, they will lose their vision. So we provide a medical and surgical management of all these pediatric cases as they present. I'm not going to go into the specifics because it's very varied, but suffice it to say that we try to provide the best service we can to these children. And sometimes it's done on a multifactorial basis. All the specialties in the department may be called upon. For example, you may have a child with a congenital cataract that gets surgery and then develop glaucoma. We involve the glaucoma specialist. I might screen somebody who has retinopathy prematurity and they need surgical intervention for the retina, so I involve the vitreoretinal specialist. So we all work together to solve these problems. So in a nutshell, that's what we do at the hospital. As far as the school eye clinic is concerned, amazingly, this was started in 1973, 50 years ago. I don't think the presence of the school eye clinic is as widely known as it should be. But it started back in 1973 and it's based at Winston Scott Polyclinic. Next slide. Children who are referred to the school eye clinic primarily are sent from schools when teachers identify that a child may have a problem seeing the chalkboard or copying incorrectly, or not doing well in school, so they send them to get their eyes checked. And these are usually between age 5 to 12. We have doctors in the polyclinics also send patients for assessment if they identify a problem. And within recent times, parents have been asking for the children to be checked if they think there's a problem. And these kids are all seen by our orthoptist, who is another important member of the eye care team. She assesses or screens every child that's referred into the polyclinic. As I said before, we have lots of eye allergies, and if she identifies that as an issue, that child is referred to the eye doctor who's resident in the polyclinic. We have eye doctors there that work every day. I myself go every Friday, except the last Friday of the month. We have 2 others, my junior doctor assists, and another resident doctor at the polyclinic. So these kids are referred if they identify suspected eye allergy. Can you go back, please? Many of the kids have refractive errors. Now, when kids are very young, we can't always assess their need for glasses the way we do with adults. So, from my experience, kids above the age of 6 or 7 can be easily tested for glasses by the optometrist. There's also a resident optometrist in the polyclinic. Below the age of 6 or 7, we find sometimes the test for glasses may be difficult, so these cases may be, you will have to be referred to the eye doctor to be tested in a different way using eye drops, which we then can measure the prescription without any input from the child. Next slide, please. And those with squints, again, are seen by the orthoptist for the initial workup. What she does, she assesses the vision, how much the eye is misaligned, and then these kids have to be tested for glasses. Every child with a squint should be tested for glasses. So they're then sent to me or my junior daughter to be tested for glasses and a full examination of the eyes, because if the eye doesn't see well because of underlying pathology, the eye will drift. So we need to check every child with a squint for glasses and the health of the eyes. So as I mentioned, in the past, we depended on the teachers in the schools or some doctors or parents to identify kids who may have a problem with their vision. And then they refer to the school eye clinic. What we're hoping to do going forward is to screen school children in their first year of school if possible. And also, like we did last year in our pilot project, screen first formers after they've done the common entrance exam. So we catch them when they start in school and when they go into secondary school. And what we're hoping to do is find these children who may have problems rather than wait for somebody to think they may have a problem and refer them. We've engaged the services of 3 other polyclinics, and I must thank the Ministry of Health and Education and the doctors in the polyclinics for allowing us to do this. We started this in March of this year. So we now screen children before they start school within the first year of school, and it is now beginning to pick up. Next slide, please. So as we monitor the uptake of the service, as more and more kids come, we may find it necessary to increase the staff complement accordingly, but that is a work in progress. Next. And as I mentioned, a lot of these kids need glasses, so at some point in time, we may have to increase the budget for glasses to treat these children. And the long-term goal, which I'm sure Dr. Drates will do his best to ensure, that we can expand these clinics to see adults so that we can take some of the referrals from the hospital into the polyclinics. And at some point in time, have a full ophthalmic service in the polyclinics, where possible. Thank you very much.
Thank you, Mr. Callender. Up next to present on glaucoma is Dr. Kyawa Clark.
So I'm hoping that during this glaucoma talk, I will answer some of the questions that, or preempt some of the questions that will come. They tend to always come when we talk about glaucoma. And also, hopefully stimulate others to ask some questions, because this is a very prevalent condition within our population. And I'm sure everyone here and online knows someone who has glaucoma. All right, next slide. Next slide. Right, so what is glaucoma? So glaucoma is actually not just one disease. It's actually a group of diseases which are complicated, chronic and progressive, but they all lead to the same endpoint, which is damage to the nerve at the back of the eye. And that nerve is very important because that sends the information to our brain, which allows us to perceive our environment. It's commonly associated with high pressures in the eye, but it doesn't have to be. And it can affect anyone, and is actually very prevalent in our region and in Barbados, with a 7 to 10% prevalence rate. And it's commonly referred to as a silent thief of sight, because many times it comes without any symptoms. So as I said, there are many different types of glaucoma, but we can broadly divide them into open angle and closed angle. And it's important to note that open angle is by far the more common type that we see in our population. So most of what I'll be referring to later in the presentation will be referring to open angle glaucoma. Next. So where did glaucoma come from? Well, there are many suggestions and much information that suggests that we actually have inherited it, and it's a legacy of the Atlantic slave trade. You can click again. All right. Essentially, our rates of glaucoma are very similar to those of our counterparts seen in West Africa. So it's quite likely that the gene was transferred over to the Caribbean during that period. Next. Next. Right, so who gets it, right? So major risk factors. I said people who are of African or Afro-Caribbean descent, as mentioned previously, people with a significant family history, particularly a first-degree relative. All right? If you've gone to get eye check and someone's noted you have high pressures, there's an increased risk of you having glaucoma. And when we go to check the eyes and we look at your nerves, some people will have nerves that look very suspicious, and I'll explain that a bit later. And those people are at increased risk of developing glaucoma. Thin corneas, advancing age, and then other reasons like similar to cataract, like drugs, certain drugs, and steroids, and previous trauma, etc. Next slide. There are also other minor risk factors, which include diabetes and high blood pressure, not particularly related to primary open angle glaucoma, but can be related to other secondary glaucomas. Also, some of the treatments, particularly blood pressure medication, can also have an effect on your treatments with glaucoma. So it's very important that when you see your doctor, especially your ophthalmologist, to let them know that you're on these medications. Previous slide. Right, migraine, heart disease, and then we need to know if you're nearsighted or farsighted, because dependent on the shape and size of your eye, you may be predisposed to different types of glaucoma. Next. So how do I know I have glaucoma? Well, big and bold, you need to check your eyes. Most times, it's the silent thief of sight. It presents no symptoms until it's very advanced. A few may experience things like pain and blurry vision, halos around lights, or headaches, but generally it's no symptoms until it starts to affect your central vision. So regular eye examinations are advised, and it can vary based on age, particularly if you have a major risk factor like family history. Yearly checks are definitely advised within our population after the age of 35 years. Next. And when you go to the ophthalmologist, what will you have done? So we need to check your pressures. We check the nerves and fields, angles, and the thickness of your cornea. All of the risk factors that will be involved in diagnosing glaucoma. Next. So how do we measure pressure? I first must say, none of these tests, although they look scary, are painful, right? Which is one of the reasons most people don't like to go to the doctor, because they think they're going to experience pain. So we can measure the pressures by various means, some of them which will touch the eye, and some of them which we don't require you to touch the eye. Next. We also need to check the nerves, right? As you can see, this is a very common machine you'll see in your ophthalmologist's office or at the QEH. Visual fields also. Yeah, you can, next slide. Visual fields are also very important with glaucoma. This is how we actually check to see how much vision is lost. And this machine is probably, this is the worst test you can get for glaucoma. It's very difficult. Some people will even classify it as more difficult than common entrance exam. Next. And this is what your field printout would look like. This is a normal field, and it essentially shows us black areas and lighter shade areas. The lighter shade areas are obviously the areas that you can see well, and darker the area, the less you can see. Black, meaning you're not able to see. That black spot there is normal. Next. So as glaucoma advances, the field or the area of vision that you can see diminishes. It typically affects the peripheral vision first, and nobody really uses that for anything. We use our central vision for everything. So we don't really notice that we're losing vision until it starts to encroach on our central vision, as you can see on the right, advanced glaucoma. Next. We also need to check the angles. Again, painless, although the picture might seem otherwise. Next. And the corneal thickness. Again, painless. We also need to take, next. We also need to take some pictures, right? These definitely will help us in terms of documentation, especially in the eye clinic where you may be seeing multiple doctors. We can all have the standard pictures, so we'll be able to follow you accordingly. And in actual fact, some of these pictures, particularly the OCT, can detect changes related to glaucoma even before you lose any visual field, which is the ideal time to detect glaucoma. Next. So how do we treat it? There are various modalities of which we can use to treat glaucoma. The most common one that most people are aware of is eye drops, of which we have quite a variety available here to us in Barbados. And the aim of treatment is to slow the progression of the glaucoma so that you can maintain most of your central vision, if not all of it, until you leave the earth. Next. But there are other modalities other than drops, which people should be aware of. One of them is SLT laser. And essentially it's a laser where we target the natural drainage channels of the eye and which allows better outflow and thus lowers the pressure in the eye. And studies show it has like a 78% success rate, meaning 78% of people will respond to the laser. That has the benefit of potentially getting you off drops, reducing your drop burden, and also preventing you from moving on to more invasive things, more invasive surgical options. Next. So what if my drops aren't working? Well, you must consider, am I taking them correctly? Many people will take the drops and they will blink quite a lot when they put in the drops. And in actual fact, that will actually push the drops into the back of your throat where they don't really work very well. Secondly, squeezing a lot, some of these drops do sting, and that can also affect the ability of the drops to work on the surface of the eye. And some of us, we just forget. Taking medication is hard. Nobody likes to take medication. But there are some people where drops are not effective, and these persons tend to require surgery, especially if the glaucoma is progressing. And surgery, as I said, generally involves either manipulating the natural drainage channels or changing the drainage channel, creating a new drainage channel. So you must ask your ophthalmologist whenever you see them, what are your options depending on your glaucoma. And after surgery, drops may not be needed at all, meaning you'll be living a life like everybody else. Right, next. So what are the surgical options? So they're minimally invasive options, which are quite minor, quite similar to cataract surgery, and also commonly done at the time of cataract surgery. And there are major surgical options like glaucoma filtration surgery, such as trabs and tubes, all of which are done at the QEH. Next. So there are generally some other frequently asked questions with regards to glaucoma, so we're going to address just a few of them. Next. Is there anything I can eat to cure or help with glaucoma? It's a very common question. Generally, a healthy diet is always advised. Some people will refer to very specific supplements like L-arginine, marijuana, and there isn't enough evidence or research out there to say the true benefit of these supplements. The real answer to that question would be, if you are going to take supplements, it means that you shouldn't negate the use of your actual glaucoma medication, whether it be the drops or the laser or needle surgery. It's not a replacement, it's a supplement. Next. Can I still drive if I have glaucoma? This is a conversation which must be had with your ophthalmologist. Many people do not realize the visual deficiency they may have, particularly looking at the mild to moderate or subtle loss in the top photos, where there's no actual black spot in your vision, but you can't see the child crossing the road. Vision is one where when you're looking in the distance, you can see quite a lot of your field. But things that are near to you, you'll notice the effects of a small field. And then there are some people who will have what's called tunnel vision in advanced glaucoma, where everything is quite dim and they're only be able to see in the central vision. So in terms of driving, as you can see, if there's anyone crossing the road in front of you, that would be a big issue. And that's something that needs to be discussed with your ophthalmologist to determine what are your defects. There are a lot of advances in technology that help people with visual disability to move around, particularly signals on your car when things are getting closer, etc. But of course, anybody with severe visual disability should avoid driving. What's the difference between cataract and glaucoma? Well, Dr. Drace did a pretty good talk about it. Cataracts are at the front and affects the lens. Glaucoma is affects the back, which is the nerve, right? So the treatment of cataracts will not necessarily affect your glaucoma per se. And in actual fact, treatment of cataracts can sometimes be used to treat your glaucoma in certain cases. Right? Next. Is there anything I can do to prevent glaucoma? Well, unfortunately, that ship has sailed across the Middle Passage. So once that your genes have been set up, that's unfortunate. You can't do anything about that at the moment. But the important thing is actual follow-up, checking to see if you have glaucoma, checking to see what the progression is, checking to see what your pressures are, if you're on medication, checking to see that that medication is working, right? The real thing is importance of follow-up and seeing the ophthalmologist. Sorry, 1 second, Bob. Most people who actually have glaucoma don't go blind. In actual fact, 95% of people with glaucoma, once treated appropriately, will keep their vision. But there are some factors that increase the risk of going blind. One of them is access to healthcare and eye care, but late diagnosis is another. So if you check your eyes throughout your life intermittently with the ophthalmologist, the optometrist, or anyone of the eye care team, that will reduce your risk. Early surgical intervention, particularly those advanced glaucoma or not really responding to medication, adherence, taking the medications, and obviously, as I mentioned, and I can't reinforce enough, follow-up. Check your eyes. All right? Next. And that's it. Thank you very much.
Dr. Clark, they're reiterating that screening is very, very important. You have to take some personal responsibility and get your eyes checked regularly. And I think, Mr. Cameron, you told me once a year. Initially, that's what you told me. Okay, so once a year, but please make sure that you get your eyes checked because you want your vision. Your vision is critical. Up next with his presentation is Dr. Charles Pierce. He's a medical retina specialist. And I don't know if you have this in your presentation because recently there was an amazing breakthrough in terms of a diagnostic test that you led at the QEH. So maybe you can enlighten our audience both here in Standard Distribution showroom and online about that procedure as well in your presentation.
Thanks very much for the opportunity to talk about diabetic eye disease. So I think you're referencing an angiogram, so that involves injecting a dye in the arm, and then we take a series of photographs of the back of the eye. And it allows you to see how the blood is flowing through the back of the eye, whether there's any compromise to the blood flow. And it's one of the better investigations that we have to see how diabetes is affecting the eye. So now we have it available at QEH as well.
An additional service that is available to, of course, all of our patients here in Barbados. You can go ahead with your presentation.
Okay. So I'm going to talk about diabetic retinopathy, and I think on this sofa we're covering about 90% of the problems that can cause sight loss. So we have cataract, diabetic retinopathy, and glaucoma. Next slide. So first of all, we need to talk about diabetes, or diabetes mellitus, which is the proper full name for the condition. And diabetes is a chronic condition, chronic metabolic condition, and it's characterized by elevated blood glucose. The most common type is type 2, and that's usually adult onset. But then there's also type 1 diabetes, which you see in younger people. Next slide. So this slide just illustrates the scope of the problem. So we're seeing an increase in the prevalence of diabetes from 2015 to 2040. There's been a 110% increase in men and 58% in women. And we're estimating that approximately 9% of the global prevalence, it will increase to 9% of the global prevalence in men and 7.9% in 2014. And it's increased further since then into the 2020s. And the incidence of sight-threatening diabetic retinopathy is decreasing in higher income countries, but in Barbados and low to middle income countries it's increasing. And the real difference has been better control of diabetes as well as screening programs, and that's driven down the prevalence of sight-threatening diabetic retinopathy. Next slide. And looking across the Caribbean, this is reflected as well, where we're seeing an increase in diabetes in the population, and as a consequence, an increase in the prevalence of sight-threatening diabetic retinopathy. Next slide. So what is diabetic retinopathy? So it's a complication of diabetes where you see leakage from the blood vessels. On the right, this is what the normal the retina looks like, which is at the back of the eye. So on the right, you can see that pale area is the optic disc or nerve, and then in the center is the fovea or macula, and that's responsible for the majority of your vision. So the retina is a light-sensitive layer of cells at the back of the eye that converts light into electrical signals, and then those signals are transmitted to your brain and interpreted into normal images that you see day to day. Over time, a persistently high level of blood sugar can lead to damage to the blood vessels, and that's what causes the problem in terms of sight-threatening diabetic retinopathy. Next slide. Almost all patients with type 1 and approximately 60% of patients with type 2 will develop diabetic retinopathy during the first 20 years of the disease. However, it often remains undetected until it progresses to the advanced stage of the disease. Next slide. So what are the risk factors for diabetic retinopathy? Anyone with type 1 or type 2 diabetes is potentially at risk of developing the condition. However, you're at greater risk if you've had diabetes for a long period of time, if you have persistently poorly controlled blood sugar levels, if you have high blood pressure, high cholesterol. Those are also diseases that work together as part of a metabolic syndrome that can increase the progression of diabetic retinopathy. And we also see a progression of the disease during pregnancy. Next slide. And what are the symptoms? The main problem with diabetic retinopathy is that there are often no symptoms until the very late stages of the disease. And if you do notice symptoms, then it often means that there's something significantly wrong in terms of your diabetes control as well as your diabetic eye disease that may be developing. But saying that, some of these symptoms can translate to other conditions, so you should always check with your eye care provider to see whether it is diabetes or whether it is something else that's causing the problem. So if you do notice a gradual worsening of vision, especially central vision, if you notice a new onset of floaters, pain in the eye, blurred vision, patchy vision, or eye pain, those are just general symptoms that can develop in advanced disease. Next slide. So I want to break down the types of diabetic retinopathy. So you have non-sight threatening as well as sight threatening. So we'll talk about non-sight threatening first. Next slide. So this is the mild form of diabetic retinopathy, where you can see you have that single dot there in the center, and that's called a microaneurysm. Essentially, it's just a dilation of one of the very small blood vessels, and that can lead to leakage from these blood vessels. But in this stage, you're not really expecting too much in terms of complication. Next slide. However, if the disease progresses, then you can advance to the moderate and the severe non-proliferative diabetic retinopathy stage. And here you can see that you have more hemorrhages, so more of the red areas at the back of the eye, as well as those yellow areas, which represents protein leakage, as well as areas where the retina is not functioning as well as it should. Next slide. So this is our main concern. After 1 year, you can have a 1% chance, if you're in the mild category, of transforming into sight-threatening diabetic retinopathy. But you see, if you have severe, you can have a 15% chance. And in the 5-year category, if you've had it for 5 years, then you have a 56% chance of progressing to high-risk proliferative diabetic retinopathy. Next slide. So I briefly want to talk about the sight-threatening diabetic eye disease. Next slide. So on the left, if you can see, there are these spidery-looking blood vessels around the pale area where the nerve is. And this is the proliferative phase of the disease. So you have these abnormal blood vessels growing, and they can start to bleed, they can start to scar, and they can actually pull the retina or the back of the eye off. So this is absolutely what you want to avoid happening. And then on the right, you have this leakage. So those yellow areas at the center, that's a protein that's depositing in the center of the eye, and that can cause loss of vision centrally. Next slide. Strange. Next slide. Yeah. All right, so there are two options really that we have to treat it. So you can use an injection, and people come into the clinic think that the needle actually looks like this, but it's nothing like that, it's quite small. Or you can use a laser, and again, the laser doesn't look anything like this. But those are the two main options that we have in terms of treatment. Next slide. So macular edema, again, you can see on the right those yellow deposits. And when we do a scan, we can see that there's these dark areas centrally, and that's the fluid that's developing in the retina. So the kind of grayish area is normal tissue, and then that kind of darker area centrally, that's the fluid that's accumulated. Next slide. And we divide it into two, center involving and non-center involving, and it's the center involving that's more of a concern. Next slide. And this is what we do in terms of the injections. So many people have heard about injections, and everyone thinks and freaks out when they think about a needle going into the eye. But it's not as bad as people think once they've actually had it. You put lots of anesthetic in, so you don't feel anything. I can say this, I've never had it done myself, but yeah, you don't feel anything, and it's the best option that we have to improve vision for macular edema. Next slide. So I'm going to talk about the other form of sight-threatening disease, and this is the proliferative form, where you have these abnormal blood vessels growing. Next slide. And the mainstay of treatment is laser. So we apply the laser with a machine looking like the top left. So you're sitting with your chin in the rest, and then you're looking through at the back of the eye, and the laser creates those tiny yellow dots, and that's the treatment. And it causes the blood vessels to shrink, and you're at less risk of developing problems in the future. Next slide. And then finally, we have surgery as an option. If the disease has advanced to the stage where injections and laser are not working, then surgery is the next option. And if you see on the right, there's that yellowish looking area over the retina, as well as lots of red area where there's bleeding. So in this stage, you would have to use surgery to try and get rid of that deposit or fibrin, the fibrosis that's there, and hopefully improve the vision, or at least stop it from getting any worse. Next slide. And then in the end stage of the disease, you can have scarring, either from deposition of the protein on the right, or from if the retina actually lifts from the back of the eye, causing a detachment. Next slide. So what I want to talk about briefly is the role of diabetic retinopathy screening. And we're trying to avoid this end stage of the disease by catching it at a much earlier stage, where you can either monitor it more frequently, or you can start treatment at an earlier stage and avoid some of these end stage results. Next slide. So the World Health Organization defines screening as a public health service in which members of a defined population who do not necessarily perceive that they are at risk or already affected by a disease or its complications are brought in to have specific tests to see if they can determine if they are at risk of its complications. Next slide. So who do we screen? So I would say this slide is a bit long, but diabetic retinopathy is essentially a good disease to screen, because we know the disease, we know how it progresses, and we have effective treatments. And if we intervene early, then we can make a significant difference towards stopping it advancing to the end stage. Next slide. And the aim of diabetic screening is primarily to diagnose, then refer, and then finally to treat the disease if it's sight-threatening diabetic retinopathy. And it's to help the patient and health professionals identify further care issues. And also we can identify other diseases, cataract, glaucoma, AMD. However, this is not the primary aim of diabetic retinopathy screening. Next slide. And we can look to England as a success story, where they've reduced the amount of blindness caused by diabetic retinopathy from their screening program. And hopefully this could be replicated in other countries as well. Next slide. And how is it done? So it's very simple. You come in, you have a vision test, put some drops in, take a photograph, and then after that, we have a look. So next slide. And either your eye healthcare professional, your optician, your ophthalmologist, or digital screener, they'd be able to see whether there's any change that's happening suggesting diabetic eye disease. Next slide. And where did that come from?
Well, we'll get this corrected in a matter of moments. As you go back to the modern digital images.
Yeah.
Is the next slide you want to?
Yes, I would just add that everybody over the age of 12 should have their eyes checked who's diabetic for any sign of diabetic eye disease. And again, so it's your optician who can have a look, it's your ophthalmologist, your general practitioner once they have the equipment, or you can go to a screening program, all of which can have a look to see if there's any sign of diabetic eye disease. Next slide. So I think we can move forward from this. Next slide. Next slide. So in summary, the prevalence of diabetes is increasing globally, and as a result, the prevalence of sight-threatening diabetic retinopathy. Many patients are presenting to healthcare systems at an advanced stage of the disease, and this is what we want to try and eliminate or reduce. Effective treatments are available once sight-threatening disease is detected early. Thank you.
Thank you very much, Dr. Pierce, Dr. Clark, Mr. Callender, and Dr. Drakes for your presentations. Before we open up the floor to questions and comments, I want to recognize some members of our audience. Of course, we have with us Senator Dr. Crystal Drake. She is a director on the board of the Queen Elizabeth. Crystal Haynes.
Yeah, Haynes.
Yes.
Haynes.
Drake's is still stuck in my mind because I have a question for him already. Senator Dr. Crystal Haynes, of course, she is the director, one of the directors on our board of management. Thank you for attending tonight and spending some time with us. We also have our director of support services, way down at the back of the class, Louise Bob. Our philanthropy officer, Gay Howell, spending some time with us tonight as well. And of course, putting this together, a big part. Two of them are a big part of the 60th anniversary committee. They're responsible for putting together a number of events as we celebrate 60 at the QEH. Also, Sophia Williams, she's also part of the 60th anniversary organizing committee. Thank you for being with us tonight. So now we open the floor to questions for our consultants. They're spending some time with you because they're the specialists in their field, and we know that you have questions. But I'll lead off because my question is for Dr. Drakes. He recently took up the position as head of ophthalmology at the Queen Elizabeth Hospital. I think our audience, both here and online, would want to know, what is your vision now that you're in charge of the department? Pun intended again.
That could be a very broad question or quite in-depth. My vision ultimately is to be able to offer care in a timely fashion to the patients, because if we're being honest, that's not happening at this current moment in time. There may be long waits for new patient appointments. There are even longer waits for surgical intervention. The new patient appointments we could adjust, or we could address by seeing more new patients, or we could actually screen the new patient referrals and see those patients who, based on the referrals, we think need to be seen earlier. Of course, that means that we also have to educate doctors, etc., to what information we need in the referrals so that we can make those judgments. Since I spoke about cataracts, I'm sure it's no secret that the waiting time to actually have cataract surgery is quite long. That is not because of a lack of expertise, but it has to do with the challenges which we face within the QEH. The ophthalmology department still continues to share a single operating theater where the surgeons are unable to work more than every other week. Simply by having another theater, we could double our output quite easily. The same Lions Eye Care Center, it is a dream of mine to actually try and see if we can move that process forward and get that opened again. Certainly the third floor, which has remained dormant for the last 10 years. So that is certainly something that I would love to see addressed during my time as head of the department. One of the other problems that we face is, I don't know if anyone has actually had the chance to come to the eye clinic on days when the clinic is in fact running. You can imagine that. You think about it, 21,000 patient visits for an entire year. Let's break that down into a day. Every day there are probably over 100 patients passing through that space. We've tried in the past to stagger appointments. It did not work because the patients still continued based on tradition to come. Everyone come at 8:30 and everyone come at 1. So we abandoned that. And we said, well, we'll just continue as is. But in recent times, as conditions in the country have changed, whether that is that we have more elderly people needing to seek care, the numbers have increased again. Therefore, we're going to have to look back at scheduling appointments, and it's going to require some education on the part of the QEH and educating patients as to how to keep their appointments.
Indeed.
Elderly people can be there as early as 5 a.m. That is really unsatisfactory. But we would really like patients, if you have an 8:30 appointment and use an 8:30, try to get there maybe half an hour before. If your appointment is at 10, don't come at 7. Because unlike previous times, if we do institute that system again, we're not going to have pity on you and see you at 8:30. We're going to see you at 10. Because the clinic has a capacity, and if you exceed that capacity, then the patients spread out onto the outside of the clinic. They spread down the stairs. They go onto the ground floor. So one of the things is actually to have patients come in a timely manner and to address them in a timely manner. To do that, we're going to need to increase our staff, because if we're going to assume that, you know, a doctor, an experienced ophthalmologist or an experienced doctor in training can see a patient every 15 minutes, it means that one person during a clinic session can probably only see about 12 patients. Currently we have, even though I listed all that staff, there are 4 doctors who are actively managing the clinic. We've separated out emergencies because we have a lot of patients who actually walk in or refer from outside. And we also have one other doctor who would actually be in theater at that point in time. So therefore, for all intents and purposes, you have 4 doctors seeing patients. So if you actually total that up, that means that in theory, every clinic session you can probably see about 48 patients. I don't think there's any clinic, any eye clinic, that has seen 48 patients or had 48 patients booked for a very long time. The numbers are in fact double that. So we definitely need to increase our staff so that we can actually offer more timely care. I think we've made efforts with help from others to make sure that we have functional equipment, but you know, there's still challenges there and we could do better. So timely maintenance programs, staggered appointments, more surgical operating time, and I think we could actually go a long way towards making the public that we serve a lot happier.
Thank you, Dr. Drakes. And that's why it's great that you're here, Dr. Haynes, because in those decision-making meetings, I know that the team is really working hard to make sure that our consultants get what they need to meet the demands of our public. So we'd like to open the floor, as I said, to questions and comments from our audience. There is a roving microphone that you can use so that our online audience can hear you and our consultants can hear your question as well.
Good evening. This question is to Dr. Clark. You spoke about the transatlantic and the genetic thing. Does that mean that Caucasians or white persons do not get glaucoma?
They do, but it's a different genetic trait that is likely associated with that. And it's actually seen the global average for the prevalence of glaucoma is around 2 to 3%. But for some reason in the Caribbean, or North American, African American counterparts, and West Africa, ours is closer to 10%. And there's actually big discussions now about mapping those genes with respect to glaucoma that affects people of African descent.
We have a question from online. It's coming from our Chief Operations Officer, Dr. Christine Greenidge, who is taking a look at our live stream. She's asking the team about wearing sunglasses for protection. And I know that you did mention sunglasses can help to protect the eyes, especially from some level of deterioration. Mr. Callan?
That is very strongly recommended for two reasons, really. You see lots of patients in Barbados with that fleshy growth on the eye called the pterygium. That has been shown to be caused or aggravated by exposure to ultraviolet radiation.
Is this the yellowing that you're talking
The
about?
triangle piece of flesh that goes across from the white over onto the cornea. So that has been shown to be caused or aggravated by exposure to the sun. So that helps, wearing sunglasses helps to protect from that development or progression. Dr. Dres also mentioned the association between high levels of sunlight and cataract formation. Early cataract, you get a lot of glare issues, so the sunglasses help with that also. We always recommend that person who spend a lot of time outdoors should protect their eyes from the sun. If you wear glasses that have a transition feature where they go dark in the sun, that's also helpful. But we always recommend protection from the sun if you can, so there's no harm in wearing preferably polarized sunglasses.
Okay. So preferably polarized sunglasses or transition lenses.
They cover more glare than regular sunglasses.
Okay. Any other questions from the audience?
Good night, everyone. My question is to Dr. Pierce. Pierce. We have a number of persons in Barbados that are pre-diabetic. So I'm wondering if you recommend that those persons be screened for diabetic retinopathy also?
So you're right. There are a number of patients who are in the pre-diabetic range. But the recommendation so far is that they probably would not need to have the same level of intensity in terms of screening as patients who are within the diabetic range. But saying that, it's good practice to have your eyes checked at least every year or every 2 years. And if there's any transition from the pre-diabetic to the diabetic phase, then yes, it would be an annual review, depending on what stage of diabetic retinopathy you are at that time.
Can I make a comment?
Of course.
Dr. Dres mentioned the need for more operating theater time, and a second operating theater would be extremely useful. But I also want to add that we need more nurses in the eye operating theater so we can actually work for longer hours. So I don't want to leave that out. We need more theater time, and we need more nursing time, nursing hours, so we can actually do more. If we have more nurses now, we can work longer during the day. And if we get a second operating theater, then to man 2 theaters with this number of nurses that we have may be a bit of a challenge. So I don't want to forget the nurses that we need.
Definitely a need for nurses. We do know that there is a plan in the Ministry of Health, and they're looking at it in terms of making a number of appointments in a number of areas. So hopefully ophthalmology is at the top of the list. I don't have a sight of that list, but we really do know that nurses, especially nurses, we're expected to get some nurses coming our way to help with the staff complement across the QEH. So hopefully that happens sooner rather than later. Any other questions from the audience? I see a hand raised, 2 hands raised. Let's start at the back.
This question is to Dr. Callender. You talked about the fleshy growth on the pterygium. One, can that cause blindness or interfere with the vision? And with regards to sunglasses, is there any kind of sunglasses? What's any dark thing you can put on, or is there a special kind of sunglasses?
Thanks for the question. As the pterygium develops, it can cause difficulty with the amount of moisture in the eye. When you blink, the tears may not spread out the eye properly, so the eyes get irritated. and it can be red when you're exposed to the sun, have a foreign body sensation. If it grows too far over the cornea towards the pupil, it can distort the shape of the cornea and make the vision blurred. If it goes so far that it reaches the pupil, it can actually obstruct your vision. You're looking through a curtain, so it's always advisable to get it removed before it reaches that stage. As far as sunglasses are concerned, polarized sunglasses, I won't call any brands, but if the sunglasses are polarized, they're better than regular sunglasses. But any sunglasses will work as long as it's a good pair of sunglasses, but polarized are the best.
There's a question here at the front.
Hello, good evening.
Good evening.
I'm going back in the past a little bit, and I really appreciate this presentation, that we will have, more opportunities to understand what is going on within our bodies, especially our eyes. Because when I was about 12 years, between 12 and 13, every other year I go to the optician now, it would have been called. I would be told that one lens is stronger now and the other one is weaker, and it would go like that, left, right, and center every time I go. So my lens will change. As I got older, I had some examinations, not tests as such, in USA, and it came to the point when the optician said to me, I didn't need glasses anyhow. But I was so accustomed to the glasses, and I mentioned to him that I need glasses because I work with a lot of figures. So he did give me a prescription from that point of view. And it was to the point where I even said, are you going to put a tint in the glass? He said, but they're for reading, not for wearing. But somehow, as I went along, I was having glasses every year up till now. And now I am developing cataract as such. But my question also is, are there any habits that can prohibit us from, besides the diabetes and the high blood pressure and so on, that we can use to prevent any damage to our eyes and so on? Because one of the things that was told to me as well is that I used to lie down and read most of the time. And I was asked to stop lying down and reading and put myself in a proper position. So I know some of it you said was could have been genetic. So I'm wondering if there are any habits that we should adopt for when we're reading, especially, whether it's like the way we hold, the distances, if that in any way can help restrict damages to our eyes. There's one other thing, but I'll wait until you answer that part.
So I may not necessarily answer your question directly, but I think certainly within the last few years, we can all agree that our world has become a lot closer. We do a lot of things on our phones, on our tablets, on our computers. And because of that, certainly not in the older people, but in much younger people, there appears to be an increase in the amount of short-sightedness and worsening of the short-sightedness. And it's thought that it's because of all the close work that we do. However, that's not the only contributing factor. Certainly in Asian countries where there's a much higher incidence and prevalence of short-sightedness, they've actually done studies in their children. And an amazing thing out of those studies was, yes, you could limit people's time using devices, etc., but the one thing that they found, which I found quite amazing, those children needed to spend more time out in the sun, on the outside, doing other things. And it was actually the exposure to sunshine and sunlight, etc., which actually had a greater effect on the incidence or the worsening of the myope or the short-sightedness in their societies. But as we come back to the reading, etc., one of the things that you can hear quite commonly is that people get computer eye disease or computer eye strain. I may be mashing some people's toes because some people go and get computer glasses in inverted commas. They go and get these special lenses which are blocking blue light. You really don't need that. What you need to do is to take the breaks. So there's a rule which you can follow, which is a 20-20-20 rule. So every 20 minutes, you take a 20-second break and you look out into the distance. As I say to all my patients, a break from using a computer or a thing, you cannot take a break and then go read a newspaper or read messages on your phone and say that's a break. That's not a break. You're doing the same thing, just doing it a different way. You have to look out in the distance. So the best thing to do is if you're in an office, you walk around and you chat. You know, you interact with your colleagues, etc. You give your eyes a break, and then you can go back. Because when we actually read, we blink less. Therefore, if you already have a tendency towards dry eyes, you're blinking less. You're gonna experience that soreness more than anything else. And reading is it's actually a very high energy. It involves quite a few muscles in the eye. So just imagine like if you were running on a treadmill for 12 hours straight, how do you figure your legs would actually feel? So you have to take those breaks and allow your eyes to relax and recover a bit. But you know, as to whether reading in the dark, etc., I know other colleagues might actually have different opinions, but I actually don't think it really makes a huge difference. But if you're reading in the dark now, you're most likely reading on your phone, and the blue light from the phone, or the phones or the devices, what actually affects more than anything else is your sleep. And sleep is also what we've realized now is that proper sleep is actually important for proper health. Proper sleep is also important for later on as you get older in terms of, decreasing your risk of dementia, etc. So you can't just think of the eye, you have to think of the eye as being a part of your body, and you have to do healthy things. Exercise, eat properly, sleep properly.
Before you ask your second question, I just want to add something that pertains to children from my experience. You find that there are a lot of kids who are nearsighted, but as they grow and they get older, they may get more nearsighted. So that's what we call a myopic shift. That's why we monitor these kids often, yearly at least, or every 18 months. Now, if you're very slightly nearsighted, as you approach your 40s and you start to get that reading problem that we call presbyopia, that's a form of farsightedness. Some persons who are nearsighted actually get less nearsighted as they get in their 40s, and the prescription for distance falls. So you find you see better in the distance as you get older. So in your case, you might have been mildly nearsighted, and as you got in your 40s, the farsightedness canceled out your nearsightedness, and maybe you didn't need glasses at that time for distance. But certainly you need glasses for reading as you got older.
You had a second question?
She did.
Yes. Something was mentioned about the peripheral vision as well. But a lot of sports people do use the peripheral vision a lot. And recently I've been involved with a group of young ladies in a sport, a team sport. And it was amazing for me because at the time that I was an athlete in those days and playing in a team game, and team games, we were actually trained to use your peripheral vision. It made it easier for you not to have to look at your next player to see where he or she was, that you can see in a distance. And I found that this group of people, they were like under 21 years old, and they were very, very poor at using the peripheral vision, like passing without looking and so on. It was like awful. And I think too, some of those things need to be looked at when we're talking about physical education as well. In that area, they can help them to strengthen that kind of vision. I am not an ophthalmologist or anything, but I'm just talking from my experience. I think that ways that we can work and try to develop the younger generation.
Thank you for that comment. We do have a question from online, from Merlene Hercules. She says, I'm so proud of Dr. Clark, and she's thanking him for his very informative presentation. She also wants to know what's the best way to administer eye drops like Travatan.
Okay, so there are numerous eye drops associated with glaucoma treatment, and they can actually be, some of them are single dose treatments, some of them are multi-dose treatments, meaning you have to take them multiple times during the day. And the most important thing about taking eye drops is, one, when you put them in the eye, you want to have a period where you just sit down, relax, close the eyes like you're sleeping to give the eye drop enough time on the surface of the eye. In terms of the Travatan specifically, or the other drops that fall within that class, the other thing is you want to take them at the same time every day. That will allow the appropriate time spacing for the drop to work effectively for a prolonged period. And then finally, some people are unable to take these drops at night time, which is many times advised. In actual fact, if you are having issues with adherence, taking at night, you fall asleep before you are able to take the drop. In actual fact, sometimes these drops, obviously you will do this in concurrence with your ophthalmologist, can be taken at other times of the day if that will improve adherence.
Thank you very much. Another question for the panel here online. Please differentiate about the use of over-the-counter reading glasses and prescriptive glasses. Dr. Driggs. All right, Mr. Callender.
I'll take it out of being, I'm the dinosaur here. Over-the-counter reading glasses work or assist you to read if it's the right strength. Prescribed reading glasses also work if they're the right strength. The difference is persons who may buy over-the-counter reading glasses may just go and buy them and don't get their eyes checked. The importance is to get the eyes checked and get the appropriate reading prescription that you need, whether you buy it over the counter or it's prescribed by the optician and you go downstairs and get it made. As long as it's the right strength, it doesn't matter if you buy it over the counter or not. The important thing is to get the eyes checked before you get the reading glasses to make sure you get the appropriate strength and that they work for you.
Thank you very much. We have a few more minutes for audience engagement. Another question?
Okay, so my question is about the school program. And I know that you would have to have buy-in for more polyclinics to come on board. But there is a polyclinic, the Morris Bayer Polyclinic. In the catchment area, you will have Coldren Parry Secondary School, you will have Alexandra, and close by you will have the Dow Jordan Secondary School. So how can we get Morris Bayer on board? Thank you.
The choice of the polyclinics was made above my head. However, we are hoping that the polyclinics mentioned on the presentation will be utilized to direct patients from the various other catchment areas so that all the kids can be seen at some point in time. And we know there's always a teething problems when you start any program, so we want to start small. We're hoping that as we go forward, we can expand at some point in time, which requires staff and equipment and buy-in from the Ministry of Health. So we decided to start small first. Some time ago, there was a suggestion to have St. John be utilized, but that fell by the wayside. So we're going to start small, and if it runs well like a well-oiled machine, maybe we can expand at a later date and have all polyclinics. To be honest, my vision is to have all polyclinics involved in eye care in Barbados for adults and children. And that way we can take some of the load from the hospital. Instead of patients being sent to the hospital for diabetic retinopathy screening, as you can see, or you have a bit of cataract, you need to go and see the eye doctor, even though your vision may be 20/20, just a slight cloudiness of lines, go to the hospital. We are hoping that we can have these patients seen outside of the hospital, in the polyclinic setting, and then get referred into the hospital when they need treatment. So maybe in a few years' time, we can have all polyclinics involved in eye care in Barbados. That's my vision. But unfortunately, I don't make the decisions. We'll be trying small steps, baby steps at a time.
It's all about primary, secondary, and tertiary health care working together. to make sure that we can have the treatment at all levels for our patients. I just want to thank some quick reminders here. Of course, thanking Sunrise Entertainment for televising this live online so our viewers at home can get the information they need from our consultants. And we're not leaving them out as well. Of course, those of you in store will be getting that $50 off your next purchase, 50%. Let me clear that up. $50 off your next purchase here at Standards Distributors, and that purchase must be $100 or more. But we are also offering the same gesture to our online audience as well. They have to send their contact info to sowilliams@qeh.gov.bb. sowilliams@qeh.gov.bb, and I will put that in our online chat. We have another question.
Hi, good night. This is a question really for Dr. Clark. Can vision loss from glaucoma be reversed?
Right, so sorry I wasn't very clear about that before. So in actual fact, the optic nerve is one of those nerves in our body that unfortunately cannot regenerate. And we have not gotten to that level of technology where we can regenerate it. So in actual fact, once that is damaged, any vision loss associated with that is irreversible, which is further doubles down on the reason why early screening and picking it up early is so important, so as to limit the amount of vision loss affecting those who have glaucoma, or to actually catch it before there is any significant loss. And that's pretty much it.
Another point to make. Now that we're back on the topic of glaucoma, I just want to give praise where praise is due. We've been talking about our shortcomings at the hospital, not enough theater time, few nurses. But I also want to thank the hospital administration and engineering department for giving us the laser that Dr. Clark mentioned. We recently got one of those lasers in the hospital a few months ago. And this is the first time we have that laser in the hospital, so we'll be using it. So thanks to everybody for that.
Thank you, Mr. Callender. Thank you, Dr. Clark. A couple more questions from the audience. No more questions? Okay. So I want to put someone on the spot here. Our Director of Support Services, of course, is the head of our 60th Anniversary Committee. And, of course, these outreaches fall under our purview. As she leads the committee, I'd just like her to say a few words about the outreach and about the efforts of the 60th Anniversary Committee. Sorry to put you on the spot, Louise Bob, our Director of Support Services and head of the 60th Anniversary Committee.
You're not sorry, Shane, but I accept the challenge. Good afternoon, everyone. Good evening, sorry. It was a long day. I want to thank you first for making the time and effort to come out to support the cause that we have expressed this evening. Our 60th Anniversary Committee, we are operating under the mantra of us being a caring community of healthcare workers who cares for our communities. And our communities spread from internal, our staff, to external, all of our publics, all of our corporate neighbors, such as Standard, and all of our external government agencies and counterparts. So this is a very proud moment for us to embark on celebrating what I called our noble lady, who stood through the test of time for the last 60 years, who has been almost a panacea in the healthcare arena for all of our constituents, our patients, our members of the public, our corporate partners, our external agencies, and international and regional counterparts. We have been a stalwart in the healthcare arena, and we want to continue to celebrate the Queen Elizabeth Hospital. We are not perfect, and there's always room for improvement, but I want the public to know that we stand as tall as we do because we stand on the shoulders of all of those who came before us, all of the past hospital directors, CEOs, our executive chairman, all of the past nurses, the stalwarts in the nursing fraternity and the medical fraternity. We stand on those shoulders today. The hospital still stands as a building, but we know that the hospital is more than just the building. It represents all of the hard work of those who have gone before, those who are at present, and we hope that somewhere in the future, maybe not in our lifetime, but somewhere in the future, that the hospital can grow into a world-class institution in a new shell, but the heart and soul of the hospital will remain as is because it is under the efforts of those who work and have worked at that institution that we remain standing, and we will continue to give of our best. Where improvements are required, we will not stop fighting to make sure that we become a brand that others will want to promote and want to celebrate the efforts that we put forward in healthcare. Thank you.
Thank you so much. Challenge accepted and challenge conquered. I'll give Dr. Haynes an opportunity to speak on behalf of the board of the Queen Elizabeth Hospital. Director Haynes.
Thank you, Shane. I just want to say it's a real pleasure for me to be back here. A lot of people don't know this, but ophthalmology was my professional first love, and I worked closely with Kiowa coming up through the ranks as a junior doctor. Dr. Drakes and Dr. Callender are both my former bosses, and I owe a whole lot to them. So I really enjoyed being back here, hearing a lot more about the work that the eye department is doing. I have to say I am particularly impressed by the eye department's commitment to continuing to service the public. From what you can tell, mostly, actually all of the adult eye patients interface in the public sector interface with the QEH. It's the only place in the public sector that adult patients access eye care. So the burden is tremendous. We're facing the increasing threat related to NCDs, the aging population. So year by year, the call on their human resources as well as the department's physical resources is increasing, and even through challenges related to the AC units and aging equipment, we're really seeing a tremendous level of commitment. I can assure you there's no lack of specialist expertise or dedication in the department, and from what I can say from where I sit, I know that the board is definitely committed to supporting the department, and we're trying to see as much as possible how we can get the Lions Eye Theatres back up and running. From what was made public through the course of the estimates debates, we know that there is money being put towards that through the capital expenditure project, and there's a lot to look forward to. I think that everyone's hearts and heads are in the right places, and there's definitely a commitment to making sure that we can improve on the chronic perennial complaints that we know are there, because I'm here certainly not in any formal capacity tonight. For me, it's more of a listening session for sure, and it's a real pleasure to be here. Thanks to the organizers and to the team from Standard as well for having us, and I look forward to the next one.
Thank you very, very much. Senator Dr. Crystal Haynes, one of the directors on the board of management of the Queen Elizabeth Hospital. I really want to thank everyone for showing up both here and online. It has been a real pleasure. I really want to thank the consultants for taking some time out of their very busy schedule to really educate the public. We are the QEH, the 60th Anniversary Committee, and all of our staff across medical and support staff, we're doing some major outreach during this year. We also have a radio show that is starting on Monday on Q100.7 FM, which will cover areas like ophthalmology, but a cross-section of everything that is happening at the hospital. You may have heard some of the challenges that we face, but you're also hearing, especially from our director and from our director on the board, how we are overcoming the challenges at the Queen Elizabeth Hospital. It's all about improving the level of care that is offered at our hospital, and that will continue, and these outreaches will definitely continue as well. We will share with you, as we did for this one, through social media and through traditional media, the occasion, the date for the next health talk. This is definitely not the last one. There are about 3 more that we'll have throughout the year, and we have selected a venue. We will keep you posted on that as well. Standard Distribution has been very, very kind to allow us into their beautiful showroom, and I must thank Ms. Halliday for welcoming us into her home. A few words from you as we wrap up things for this first health talk, Eye in Focus.
So I'll make it very brief. I want to thank each and every one of you for attending and for engaging and asking very interesting questions. Some questions that I didn't even think about until you actually asked, and we were able to learn a lot from it. I want to thank the consultants for very interesting presentations this evening, and I want to thank the QEH team, in particular Sophie, for allowing Standard to be part of this. We really enjoyed this session. We're looking forward to many, many more. I hope that you all enjoyed the time that you all spent here. I hope you were comfortable, and we hope to see each of you all again. Thank you.
And that's where we wrap up things for this edition of Health Talks. The topic was Eye in Focus. Again, thank you all for coming. Thank you, consultants, and thank you, our viewers online. Looking forward to seeing you next time.
I am Leanne Solandi, Quality Manager, Queen Elizabeth Hospital. As you are aware, we recently achieved our gold level accredited status from Accreditation Canada. And you are probably asking yourself, what does it mean to be an accredited hospital? Well, I'm going to tell you. Being an accredited hospital means that the Queen Elizabeth Hospital is a place where you can come and receive safe care, and the service that we offer and the care that we provide matches international standards as far as quality and patient safety. It also means that we are preoccupied and focused on ensuring our wait times are kept to the recommended levels, as well as we manage and ensure that patients do not get infections while they're in our care. So all these are some of the little things that are big when focusing on our accreditation program. Our accreditation process started in 2017. And we were accredited, and we were in the cycle for 3 years. So we were accredited with conditions from 2017 to 2021. To get accredited is a journey. There are several things that we must do. So we have a booklet of standards that we have to work through to ensure that we practice these elements at the hospital. So what I found in working through these standards, we already practiced all of the standards. What we needed to do was to put things in writing and documentation, to have policies, create plans and frameworks. But as far as the practice at the institution, we were already practicing the recommended standards for safe care. Another part of as well, in becoming accredited, we have to do surveys. You have to survey the staff, get the staff opinion on safety, on patient safety. We also have to survey our clients, our patients, to get their opinions about the quality of care that we offer them. So it's a lot of surveying between patients, between staff, between and relatives, so that we can drive improvement and meet the standards as we go through the process.
Hi everyone, I'm Dr. Danielle Reed-Melillo and I am a general physician, and today we're going to talk about obesity. Obesity is an NCD. An NCD is a non-communicable disease. Basically, that's an illness that cannot be passed from one person to another, such as diabetes, hypertension, or cancer. In contrast, a communicable illness can be passed between one person to another, such as COVID or the common cold. The BMI is the body mass index. Obesity is defined as a BMI over 30, and overweight is a BMI over 25. Your body mass index can be calculated online or at your next doctor's visit.
Hi, I'm Carl Padmore, Public Relations Officer of the Sanitation Service Authority. Maybe you would have witnessed roadkill, or you would have passed the highway or a byway and seen a dead animal. We want you to report it to one of the numbers coming across the screen. We'll come and we'll remove that dead animal. Also, if you have an animal who has passed away at your home, we prefer you to do it the legal way than to throw it into the gully, contaminate the gully, and then we have problems. Barbados, we love our environment. Let us care our environment. Therefore, the correct way to dispose of dead animals, call the number coming across the screen. We are here to help you. The SSA cares. Clean thoughts, clean living, clean nation.
So with this accreditation, in this accreditation cycle, 2023 to 2026, one of the elements that we had to focus on a lot was the delivery of people-centered care. So we will be doing things a bit different at the hospital going forward in the way we involve and include the patients in care. We are aiming to have more communication with the patients and get more feedback from our patients so that they can be a part of the care and be seen more as a partner in the care process. And we'll be working together, doing things with the patient, providing care with the patients and not providing care for the patient. In terms of accreditation, accredited status, we compare, I would say, on par or even better. In terms of, remember, accreditation is a standardized program. Ensures that safety standards are maintained. And safety standards are just that, a standard. So every other accredited hospital will have to follow the same standards. So you'll find accredited hospitals in the United States, accredited hospitals in England will be practicing the same standard of care as we do at QEH because of our accredited status. And that's one of the benefits of accreditation. As a quality manager, I am very proud of my institution. I'm very proud of the Queen Elizabeth Hospital for having achieved gold level status accreditation with Accreditation Canada. We actually scored, we met 90%, 91% of our standards overall, which is a very good achievement for an institution in the Caribbean region, an institution where we struggle for cash. We make do the best we can with the resources that we have, and I'm very proud of our hospital for achieving such an award.
Welcome to my second home. I am Dr. Dana Watson, official title being Host Officer Watson at the QEH, where I'll be interning for the next year. I'm currently on surgery in the urology department, but I would like to specialize in obstetrics and gynecology in the long run. I always had this thing where I would take care of my dolls, want to take care of my granny, and my granny always used to be like, oh, you're going to be a doctor when you grow up. I would go around my cousins, and I would hear it all the time. So I don't know if it was the fact that I heard it constantly. And then it got a little bit deeper when I started to go to lessons, and I was talking to my late teacher at the time, and she was expressing almost in tears about the lack of a particular specialty being pediatric oncology in the region. Now, at that point in time, I wanted to go into pediatrics. And when she brought that idea of the fact that it was needed in the region and how much depth she was in, having to go overseas and how much time it took out of them and how much effort it was just to get treatment, I started to look into pediatric oncology. However, as I got to QEH and started to study medicine, learning the difference about life and death, giving birth versus having to break the news to parents about, having a child that now has cancer or having to, treat children for cancer, I realized that I might not really find my love in pediatric oncology, but the joy that I have when I see a baby coming from the womb and the mommy being so elated and even daddy being like, oh my gosh, this is my firstborn, my secondborn. It's just that energy and livelihood being brought into the world has really geared me towards becoming an obstetrician. You could spend 5 years studying medicine and doing what you actually want to do, or you could spend 1 year after year after year trying to find something else that you would like to do, and guess what, you would still add up to the same 5 years. So at the end of the day, it will take some encouragement. There would be days that you would think like, why did I choose this? But at the end of the day, you have to remember why. So my reason was always the fact that, as I said, patients depend on us. And I love when a patient can look at me and say, thank you, doc. So going forward into medicine and just knowing that I have that effect on society where patients or people turn to me for advice, for any sort of help, is what pushed me and kept me here and kept me going.
Hi everyone, I'm Dr. Danielle Reed Melillo and I'm a general physician, and today we're going to talk about exercise for obesity prevention. Exercise is important for your overall cardiovascular health and it's excellent for obesity and overweight prevention. I'd like you to aim for at least 4 days of exercise per week, and this exercise should consist of resistance training and aerobic exercise. You also want to have an exercise that you enjoy, and this will help you to stay consistent. Some examples of exercise could be walking your dog, walking with friends, swimming, or exercising at the gym with your trainer or with a group of friends. Exercise is also great for mental health and for stress relief.
Dr. Javon Rock, a 23-year-old host officer at the Queen Elizabeth Hospital, with future aspiration of becoming an obstetrician gynecologist. So I wanted to become a dentist because my dad is a dentist, as well as my uncle. However, while at the Barbados Community College, I found an interest in becoming a doctor while volunteering at the Queen Elizabeth Hospital. I did this in the year of 2018, and from that experience, that changed my trajectory into medicine. So looking back at medical school was difficult due to the fact that it was during the COVID era. So a lot of things we had to go above and beyond just the experience. However, though, I think the University of West Indies did a good job trying to get us to the point that we were at to be able to set our exams. Medical school was difficult based on the amount of material you have to cover. However, I think that the journey was made better based on good lecturers, as well as one of my role models, as well as mentor, is Dr. Kenneth Connell, Deputy Dean at the University of West Indies. So what surprised me the most about being a doctor is the amount of writing that we have to do. It might sound surprising, but we actually have to write the pre-op list, post-op treatments, writing the patient notes, as well as writing sick papers. All of these things took a bit more time than I anticipated, and that really has been one of the more difficult challenges for me. But outside of that, nothing really surprised me. What I want persons to understand or know about doctors is that we are human as well. We understand your problems. However, we are seeing multiple patients at one particular time, and we do care about you. We just have to see a lot of persons. What I want to get out of medicine is that I want to work on or contribute to our healthcare system. I see a gap in the field of obstetrics and gynecology, and I really would like to fill that void. I really want to send a message to all the young men out there that are trying to achieve something in their life, that medicine is also an option. We do need the male presence in the medical field, and the fact that it is so female dominated in my generation, I think that anything should always have balance.